To the Commission on Excellence in Innovation and Health, or the CIH, Improvement and Innovation Showcase for June 2026. This series is all about clinical registries and how we can improve care through quality insights. My name is Tina Harden and I'm Executive Director of Clinical Informatics and Innovation at the CIH. Firstly, we would like to acknowledge that the land that we are certainly meeting on today is the land of the Kaurna people, and we pay our respects to their spiritual relationship with their country. I would really like to acknowledge the Kaurna people as custodians of the Greater Adelaide region, and that their cultural and heritage beliefs are still as important to the living Kaurna people today. And particularly welcome those who are meeting or participating virtually in our online webinar today from other Aboriginal lands and Torres Strait Islander lands across the country, because we certainly have a cross-jurisdictional audience today. Well, this is the Series 19, as I said, Clinical Registries, Improving Care Through Quality Insights. Clinical registries play an important role in improving healthcare by collecting and analysing patient outcomes. They help clinicians and services understand where care varies, compare performance, and use these insights to improve care over time. That's why clinical registries are a key focus within the CIH under our priority focus area banner around data-driven clinical decision-making. This reflects our commitment to improving how clinical registries are developed, connected and used across South Australia and potentially beyond. This is the second episode where we are examining how data ecosystems can be designed in ways that unintentionally reinforce inequities, including how Indigenous data are represented and utilised. Through investigating examples from the Northern Territory, the episode also showcases how Territory Kidney Care and the NT Kidney Dashboard are supporting earlier identification and management of chronic disease. It is my huge privilege to welcome these two speakers today. They are both people who, one I've met recently, one I've known for a few years now, and I couldn't think of a better lineup for today's subject, and I think you should all be fully excited. So without further ado, we have Associate Professor Courtney Ryder from the Flinders Health and Medical Research Institute at Flinders University. Courtney is an Aboriginal injury epidemiologist and researcher at Flinders University, specialising in Indigenous data sovereignty and improving health outcomes for Aboriginal and Torres Strait Islander children. She also co-directs the Health Equity Impact Program at the Flinders Health and Medical Research Institute. Her research focuses on Indigenous data sovereignty and innovative methodologies to reshape narratives around Aboriginal and Torres Strait Islander health. And I'm also very privileged to introduce Associate Professor Asanga. He very kindly said I could just use his first name, thank you, who's a consultant nephrologist at the Royal Darwin Hospital. Associate Professor Asanga is leading kidney care services across the Northern Territory with a focus on remote communities and innovative models such as telehealth. Dr. Asanga was the clinical lead for home-based renal replacement therapies in the NT and was instrumental in establishing renal telehealth clinics to remote communities such as the West Arnhem Lands, Katherine East and West and Port Keats. Asanga is a clinical lead for the Territory Kidney Care and has led the development of the diagnosis algorithms for the TKC for short. So without any further delay, I will pass over to Professor Ryder.
Excellent, wonderful. Thank you very much for having me today. So I'm going to be speaking to you about the topic of equity for whom, particularly in terms of ethics, governance and data sovereignty in clinical quality registers, but also in terms of the items that are in those registers as well. Before I get started, I would like to acknowledge that I'm presenting from Kaurna Yurta today, and I wish to pay my respects to elders past, present and emerging. I'd also like to highlight Larrakia country as well, which my colleague is likely conferencing in from today as well. I'd also like to acknowledge other Aboriginal and Torres Strait Islander and First Nations people who might be joining the conversation today as well. So I've got a little bit of a hypothetical case study here for you. As it was mentioned before, I'm a trauma and injury epidemiologist, so a lot of the examples that I'm going to draw on today are very much from here. So I've got a hypothetical case study here. You have got Rupert Murdoch, you have got Crocodile Dundee, you have got Scrawny, football legend, you've got Albo, and you've also got an Aboriginal elder there as well. So if each of these individuals lost their leg through a shark attack, which is highly possible down here in South Australia, given all the great white sharks that we have here, could they expect to have the same health outcomes? Would they get a fit for purpose prosthetic to meet their every needs? And would their health related quality of life outcomes return to pre-injury status? Well, we know that Rupert Murdoch, well, he could pretty much purchase a human leg if we want, or he could get the Terminator's leg if he wanted. He can afford anything, but we can see Crocodile Dundee there. He's got a fit for purpose one, along with Scrawny and Albo as well. But statistically, and what we actually know in the data in this area here is that our elder here, if he has any comorbidities like diabetes, or so forth, they're going to impact on his outcomes. So what we do know in the literature is that he's more than likely not to get a prosthetic that's actually fit for purpose. And as I mentioned before, if he has any significant comorbidities such as diabetes, his mortality, he might expect to live for another couple of years. Yet one of the impacts, I guess you could say, is that our clinical quality registers and certainly our clinical quality indicators, they don't capture these nuances which impact on our priority populations in these areas. So you're going to hear me use this term a lot here as well. So we're talking about, when I'm talking about equality is the same outcomes for people. So you might have seen this picture before. It's generally I think a baseball field. Well, I AI'd it to be football because it's like, this is Australia, this is what we need in Australia, AFL everywhere. So equality is about everyone having access to watch the football. Equity is about actually changing, that access. So everyone is actually able to view it. They don't just get access to it. They can all view it in a very meaningful and appropriate way. But the reality of what we see is obviously over here in terms of the significant inequities in outcomes there. And when I'm talking about priority populations as well, these are the priority populations as defined by the Australian Preventative Health Strategy. So you'll see that there's a range of different priority populations that are captured here. And I am going to focus in on a couple of these today. So I'll be focusing obviously a lot in my work around Aboriginal and Torres Strait Islander communities. I will touch on some work around culturally and linguistically diverse, but I'll also look into rural and remote areas as well. As I mentioned, injury epidemiologists, so all the examples you're going to get from me are going to be very much injury based. So when we're talking about the equity gap, I want to provide you with an example around injury. So in terms of injuries, what we know from priority populations in this area is that for rural and remote communities, their injury hospitalisation rates are very much increased. And this increased rate we actually see occurs with increases in remoteness in that way. In terms of culturally and linguistically diverse communities, we know that there's underreporting in this area. And that's because a lot of the data is misrepresented because these data ecosystems or these registries don't have clinical quality indicators or measures that really sort of capture what it is to be a culturally and linguistically diverse person. An example that I use from a colleague who used to work for me, she was a Bangladesh Muslim woman, but she was born in London and she spoke English. So the current measures around English spoken and where you were born don't actually capture who she was as a culturally and linguistically diverse person. And then for Aboriginal and Torres Strait Islander people, we know that injury is the third leading cause of death and the second leading cause of disease burden in this space. And the impact that we see within this is that inequities are further compounded in trauma and injury systems. So these systems are very much built upon Western biomedical concepts of health and systems of care. And while they've demonstrated reductions in reducing injury mortality and improving survivorship, this is mainly within the dominant population. And there's significant inequities are apparent because these one-size-fits-all models and concepts don't actually apply to, I guess you could say, priority populations, particularly those who are at more at-risk groups. We know that there's different requirements needed. So for instance, we have different models of care for pediatric patients in trauma, also for elderly care as well. But we're yet to address priority populations, particularly the needs of Aboriginal and Torres Strait Islander communities in this space. So, who gets counted? So, in many clinical quality registers and in the creation of those items for those as well, a lot of them are very much based around health service ascertainment. So, they only capture individuals who are actually engaging with, say, specific hospitals, services, or procedures. So, it doesn't actually capture that inequity and access to care if a person can't actually get there in the first place. So implications in this area actually include that equity gaps may appear small or disappear entirely because those most affected are actually missing within this data in this data space. We also find, and certainly some of the registries and data assets that I've worked with in this space as well, is that there's significant challenges and expansion barriers as well, because quite often you've got systems or data ecosystems that have been developed and created before thinking about priority populations or before thinking about things around Indigenous data sovereignty and governance and so forth. So they're already sort of developed without that consideration. And for many, they don't know actually where to start with these expansion barriers. So there's discomfort, so well-intentioned, but don't know where to begin. Very, very worried about getting it wrong, so don't want to, include it at all. And so, there's no obvious real frameworks or policies in this area to support. And they're afraid that it'll be onerous and lengthy. So, and they don't know how to report or discuss these outcomes. So we find that these are some of the real big expansion barriers and challenges to certain registries and data systems from engaging with thinking about, well, what does Indigenous data governance processes look like that can actually meet sovereignty in our systems? And in this way as well, we find that there's invisibility by design. So as I meant before, a lot of these systems are built on sort of Western biomedical sort of clinical structures and so forth, which poorly define those priority populations. So you may have a registry which captures data and there might be Indigenous data or other priority populations sort of evident, but because there's certain items that haven't been created with community or consumers in that space, these different priority populations are actually invisible by design. So what the implication here is that what is not measured cannot be improved, and inequity is normalized as being unknown in that space. And this reminds me a lot of this picture here. So this is a good old Where's Wally image, and it was the 25th anniversary of Where's Wally, and they did a little bit of a scenario for Bondi Beach. And I remember showing this to my 11-year-old daughter. And I said, so this is apparently Australia, and this is Bondi Beach, and it's Where's Wally, and you've got to find Wally. And she looked at this and we were talking a little bit around what it represents and what is being represented and what's not being represented on Bondi Beach. And she said, well, Mum, me as an Aboriginal person, I'm not represented in this image. Sure, there are some people who look Aboriginal here, but there's nothing that represents me, who I am, my culture, or what I identify with. And this is often what we see in the data. If it's not well defined, we can't see it. And if it's not there, it's actually invisible. So we really need to look just beyond capturing ethnicity to really think about relational and representative indicators of care in this space. And just in case anyone was really, really worried and are getting really stressed, that's where Wally is right there. So what impact could this have when we're looking at clinical quality registers and reporting? So this is some work that, and the QR code's there if you'd like to have a look at the paper. So we did a desktop review and an audit where we called up different registers and we reviewed all of the clinical registers that are actually reported in the clinical registers of clinical registers. So there is a register that has all the clinical registers in Australia. And what we found at that time is that there were many clinical quality registers, not all of them actually recorded ethnicity. And you can actually see that up there. So only about 60% of all of those registered actually did that. 9% were unknown. We found that only 58% had Indigenous status. And of those that did record ethnicity, there were 16 different formats, which also included different tautologies that didn't make sense either. So it was quite clear that consumers or Aboriginal community controlled health organisations or so forth had actually been consulted or considered in the way that these registries were actually designed. And so some of you might be thinking, well, what kind of impact does that have here? Well, let me lead you on to this example here. So I've been a part of a project called the Australian Traumatic Brain Injury National Data Project. It's been a great project through with colleagues from Alfred. That for this particular project, we had an Aboriginal and Torres Strait Islander data governance group that actually saw all of our stuff. But we had a very interesting situation here in terms of, at that time, the Australian New Zealand Trauma Registry wasn't actually recording ethnicity data as well. And this project was all about reporting on the predictors or the prognostic factors that got you home alive and healthy. So I could tell you on average that there are 9 hospitalisations and 1 to 2 deaths a day for traumatic brain injury in the Australian population. But I can't tell you what that is for Aboriginal and Torres Strait Islander communities. The only data that we had in this area was actually coronial data. And, you know, death data is not a good outcome and not a good indicator for getting home alive. And what I can tell you for my First Nations brothers and sisters is don't move to Queensland. You have higher odds of a TBI mortality outside of hospital over there. So other things that we found as well within some of the research that we've done as well is this specific stuff around significant governance gaps as well. So we've got registry governance structures, steering committees, advisory groups, and so forth. They're often made up of sort of clinical teams and different representations, which are very, very important, don't get me wrong. But in relation to community and consumers, particularly Aboriginal and Torres Strait Islander people being represented on there, it is not a space where there is representation at all. And so what this means then is there is an absence of research priorities within that area because, you know, community are not being able to input into that area. Data interpretations lack cultural and contextual grounding, that real relationality. And quite often there can be decisions about data access and processes without considering the impacts on priority populations, particularly around consent and benefit and so forth. And, you know, these kind of practice can really perpetrate sort of historical extractive practices that really relate to ongoing colonisation in Australia, but also can result in sort of like policy or models of care change being changed without the consideration of priority populations. And so what we found in terms of the article that I mentioned before in here, when we looked at both governance and ethics in this space, we found that there was only Indigenous representation on 8 out of all of the registries in Australia. There were only 8 that had that as a set role and representation. What we also decided to do as well is drill into seeing which registries had Aboriginal human research ethics approval as well. And we found that there was quite a difference in that as well. So as you can see, we had 11 registries in total that actually had that ARIC approval. And 7 were actually reporting on ethnicity in that area. But what we found, which was quite concerning as well, is that there were 45 registries that didn't have ARIC approval, and 29 of those registries were still actually reporting on Aboriginal and Torres Strait Islander data without any governance or oversight in that area, or approval, I guess you could say. So the other thing that we found as well is that often within registries or research programs or different data systems is that they will sort of measure sort of some things. So quite often we'll have measures like health-related quality of life, functional outcomes, which are psychometrically assessed, are approved and are appropriate within the dominant population. But these particular tools or measures actually haven't been approved or haven't actually been assessed or considered for use within priority populations, particularly Aboriginal and Torres Strait Islander communities. So they can often lack that relationality, I guess you could say, in that sense. So how do we know what we're measuring, or how do we know if we're measuring is correct, or so forth as well? And so these can create big significant challenges in the area in terms of cultural safety, structural barriers, you know, misclassification of system failures, and so forth as well. And these are things that really sort of need to be thought about in, if we measure it in this way, is that measure going to be relational for everyone who is there? And is this going to show a good clinical outcome for one population and not the other? So an example of this in terms of some of the research that I've done. So this is an example in Burns around clinical quality registers. So they published a paper talking about how they'd done some fantastic work, which they had done some fantastic work. They'd looked at updating their clinical quality indicators. They had 9 modifications and 8 new indicators. When we reviewed that piece of document, we found that no indicators were focused on equity, and certainly there were no indicators that actually included broadening or contextualisation, particularly for Aboriginal and Torres Strait Islander communities. So we actually wrote this back and sort of kind of challenged them in a very structural and a positive way, and it has been structural and positive, working with that group to sort of say, this is really good work that you've done, but you need to broaden this further, and you need to think about how we can use this work to really bridge inequity gaps and divides, which they wrote back and said, yes, you are right, and we do need to work in this way as well. So clinical quality registers are not neutral. I know people love to say that they're neutral, but that is colleagues and somebody is walking past their house, obviously, and how dare they walk past their house? They must be told off. So clinical quality registers are not neutral, and equity actually has to be designed into these, so we need to sort of really look at that shift towards ethical governance, meaning community partnerships and data sovereignty aligned with practices that are not optional, that are actually foundational, ingrained, and created throughout the whole entire process. And so what investment is needed here and what challenges going forward? I think these are sort of the main things. We need to look at things around power sharing. We need to look around proper Aboriginal and Torres Strait Islander leadership in this area, really building those relationships and trust in the space. So kind of looking about, well, what does data reciprocity look like if we're being extractive in taking this data? How can we ensure that this data is actually translated back to community in a meaningful way that supports health outcomes or creates prevention or so forth? We need to look at workforce development. So how do we ensure that non-Aboriginal people are working culturally safe with data, but likewise, how do we, create the next generation of deadly data nerds, I guess you can say? We need to look at cultural validity and long-term sustainability and having accountability for impact in that area as well. So this is, imagine this is my utopia. So this is what clinical quality registers and so forth could look like in my ideal world, where you have them going in, you've got your data custodians, you've got your governance of Indigenous data, but then this data as well, while it delivers insights, there's whole data access areas as well, where we have Indigenous data governance over this, but this data is also meaningfully being translated back to yes, we don't know what we see or we cannot measure, and this has to change to be community appropriate. We need to ensure it's not just one dog that's getting their cake, that it's all the dogs that are getting their cake, or all the dogs get to bark out the window at the person walking past in my case. So that is the end of my presentation, and I'm really looking forward to answering any questions that you may have, and I wish to hand over to my colleague now for his presentation.
Over to you, Asanga. Thank you so much, Courtney.
Well, thank you very much for inviting me to this forum to present about TKC. So I'm a kidney specialist, and I've been working up here in the bush for nearly 14 years. Now, before we start, let me start by acknowledging the Larrakia people, the traditional owners of the land from which I'm presenting today. And I like to extend that to all First Nations people who are there in this presentation. So so as you know, your topmost neighbor, the Northern Territory is spread across a vast region. We have a very small population, 250,000, and we have 6 major hospitals. Some of them are quite small, and about 70 plus primary healthcare services. So it's a large area, but with a lot of different clinics. About half of them are sort of run by the government. So I suppose one of the biggest motivations was that we had the EMR, which has been used for a number of years, so that the same EMR was used for nearly 20 years. and we have a good cross-sectional data for primary care, tertiary care as well. So that was all sitting in a data warehouse. And then there was the need for a registry as well, the same, I suppose, for any jurisdiction where you would want to use cumulative data for forecasting and reporting, etc. Then there was also the need for clinical decision support. As you know, we are very poorly resourced. A lot of these clinics do not have doctors. They are run by very experienced nursing staff, and there was a lot of turnover amongst the doctors as well. So bearing all those three sort of requirements, we decided to build a solution called TKC. So it is a sort of a hybrid system that is kind of like an EMR, but also a registry at the same time. So as an EMR, it not only sort of gives clinical information, but also clinical decision support as well. So this is the sort of journey. It started, as you can see, more than 10 years ago. Most of the work was actually relationship building. The technical part was probably easy. You could imagine how difficult it would be to bring together so many different organizations to agree to share data. So I think that's the situation in most jurisdictions. So at the moment, we have nearly 90% participation. So that includes the NT government, and most of the Aboriginal controlled health services have actually signed memorandums of understanding to participate. There's only one that hasn't signed up. And we are in the process of also getting other private GP practices to participate as well. So it has really very good coverage. Now, before that, one of the questions that comes up is, what's wrong with the existing EMRs? Why do you need to go ahead and create a new one? So those of you who are clinicians will know that EMRs do serve their purpose, but they are nothing more than information storage receptacles. You don't really have much control on how information is processed inside an EMR. So much of the processing actually happens in the clinician's head. So you would need to extract information from the EMR and then build what we call as phenotypes. So these are mental constructs that we use to understand and manage clinical problems. So this is what the underlying substrate of TKC is all about. It's a repository of phenotypes. So these phenotypes are computed from clinical data that is sitting in the EMR almost real time and presented as easy to digest and understand concepts. Now, it's easier probably for me to show what it looks like than trying to explain it. So this is how it looks like in our EMR. So it is integrated into the EMR. And those of you who are clinicians will recognize what this is used for. So this is actually the ability to generate one-page summaries of vast amounts of information. And depending on the different use cases, now this is a very what I call a renal centric view of the problem, but it could be sort of devised into a cardiology or primary care focus sort of view. Again, these are sort of snapshots of the clinical, how it's presented clinically. Again, if you're coming from an academic or research background, this may not make much sense, but this is how clinicians use it, and most of our users are clinicians. So how does it help? So it helps to process clinical information really quickly. So people who use our system find it really easy to digest, make clinical decisions, and then it is also used for documentation, because it sort of serves two purposes. The construct that TKC sort of creates are similar to how we document it. So it is helpful in both those two workflows. It also creates alerts because it can recognize phenotypes. Now, a phenotype could be anything. It is a phenotype could be, for instance, something adverse. An adverse effect could be a phenotype as well. A phenotype is anything that a clinician would think is a useful abstraction of clinical information. So that's the key here, is abstraction of information, not the information itself. So this is how we use it in clinical work. Again, it helps to automatically identify, triage referrals, avoiding unnecessary waiting for patients, and then there's monitoring built into the system. Again, these are different views how it is seen. So because the abstractions are not actually how it is visualized, but the abstractions can be visualized in any way you want to present it. So I don't know whether that makes a lot of sense, but if you use the system, you will understand it. Now, the clinical information is also used as spreadsheets. So you can, what I've shown you earlier is for a single patient, but it could be used across a group of patients as well. So we have that built into TKC, where you can generate operational reports and use it for clinical practice and trying to identify problems. Now, but I think what is more relevant for this forum might be how we use it for service planning and research. So, so some of the things that I've listed there is one common thing is you obviously need to know the workload, what you're dealing with, and how to plan for that. Then again, the forecasting, how do you cost things? If you don't know what the numbers are, you really can't build models or make any predictions. The gaps of the service, and then once you've come up with solutions, how do you monitor the performance of those clinical service improvements? These are reports that TKC generates. The reports, the clinical information that is presented to clinicians, and these reports use the same substrate. So they are not, although they are used for different purposes and have different audiences, it is the same information. So this is the sort of thing that a registry would probably deliver. And so there's no need to do second step computing, because that it starts off with that. We use again, these are very I suppose examples of kidney disease. How would patients progress from one stage to another? Only TKC can give this kind of information. It's because we collect information from multiple sources, and we have the ability to homogenize the information. And actually, even a simple thing like CKD, it's a very complicated definition, isn't it? You can't just use coded information, so they need to be calculated. And without having the ability to calculate phenotypes, you can't derive this in a conventional sense. Now, this is again just looking at resource allocation. So I just like to spend a little time explaining how TKC works. So we did see how it's used in the clinical setting, how it's used from an operational and reporting point of view. But how it works is we do get the majority of information comes from the enterprise data warehouse, the NT government. So that does collect information from the hospital and a number of primary care data sources, but we also have external EMRs that contribute to TKC. The entire thing sits inside the NT government digital infrastructure, so it has all the security coming with that. Now, these are the pieces of how it works. Again, if that is if you're keen to know how the system is built, this is the sort of slide view. All the pieces of this software has been built by us, so there is no proprietary sort of vendor software, and because of that, we have full control of the entire stack. Again, TKC in itself has its own programming language that is used to derive these phenotypes. So what it looks like is that a phenotype is nothing but a step of a series of steps of logic that is written in a specific language. And what we do is we have made it transparent so anybody can look into how is this phenotype coded. So, and we encourage people to review them, critique them, find problems in it. So it is very transparent. Let me give you an example. If I say, who is a poorly controlled diabetic, that is a phenotype. So that is probably more than one phenotype. You need to first work out who is a diabetic, and then apply what would we define as poor control. So again, that's entirely controllable from the clinicians and so the phenotypes could be very simple, but you could build more complicated phenotypes using them as little Lego bricks. So you define small phenotypes, and then, for instance, a remote patient, the concept of a remote patient is a phenotype. So you could use that and then get the phenotype for diabetes, get the phenotype for chronic kidney disease, put them together and define, a patient with remote patient with diabetes and chronic kidney disease. So that's how it works. And I think this is fairly unique. You will not, certainly we haven't seen in our work any other system that uses this kind of approach to this. Now, once you have the phenotype, again, I kind of mentioned it, but probably I'm not very good at explaining it. But once the phenotype is derived, it could be used in as a sort of a visual summary, or it could be used for other calculations as well. Sorry, I'm very technical with this, and I'm not sure how easy it is to digest. Now, you might think at this point, look, we are in 2026, we have AI, why do you use this simple algorithms? Can't you just throw in a big, large language model and expect it to come up with these phenotypes? So that probably doesn't work like that, because as you know, of those who use AI, you have a limited context, so you can't just throw any amount of information at it. The AI will start. The approach with AI is it's not deterministic. It's to a certain degree random, and you don't certainly want that with clinical information to get different answers at different times. So and it's not easy to troubleshoot and audit using that approach. But on the other hand, we do use AI quite a lot, because now almost all phenotypes are derived using AI. So we use AI to do the research, understand how a phenotype is defined, build the phenotype, and do the testing as well. So we do use AI quite a lot, but the AI is not used to process the data itself. In other words, we are generating the code that will be used to process the data. So Look, I think I'll leave some time for questions. I thought I don't want to make it too complicated. If I have made it very complicated, apologies. But I hope that you kind of got the gist of what we've been trying to do up here. Thank you.
Excellent work. Thank you so much, Asanga. You've effectively built a series of virtual registries, a learning health system, and an integrated data platform all in one. So, and seem very humble about it. But yes, it's very amazing work that you guys have been doing there.